For today's session, like how I usually go about this CSOM's commerce thing. First of all, I must tell you that this is this is the most important thing of the entire DNB exam, or I'll say any other exam. Like there are 2-3 of you from the DLO candidates. Okay? So this is the most important thing of all. If you flunk in CSOM's commerce case, so definitely the chances of passing the exam are very less. Okay, so you should pay your utmost attention to this long case. And for long case, I keep on repeating, 90% of the time, generally you'll get squamous only. See, few decreasing percentage for your thyroid presentation or malignancy of oral cavity larynx, or if you are highly unlucky, then something else might come. Okay, so important things first. You cannot, and I repeat, you cannot make a mistake in the basics of CSOM's commerce. Okay, I'll say most important thing for you for the exam. Okay, from wherever you study, it's not that you go through only this is important. No, that's not the case. From wherever you study it properly. Don't take any chance in CSOM's commerce. Okay, in case of any doubts, please get back. We'll discuss it over the next 2 months so that your preparation for CSOM's commerce should become an impeccable thing. Okay, so how I've planned this thing. In the initial half of the class, I'll take you as a virtual viva kind of thing, like how would you approach the case, okay, and like what all the possible questions can be there, how you should approach them, what can be the possible answers. And in the next half of the class, I've taken a sort of case presentation, that what kind of a case presentation you can take. In May, all the things from history, all the things from examination findings, and what all questions can come, that I have discussed. Okay, so generally, let's start. Generally, it will be your long case. Okay, now what happens is you can get it in 2 options. One is the traditional, or the what we teach in the institutes. Like you happen to start in your hospitals, like they'll ask you what is the history, then you come to the findings and all those things. Okay, and normally what happens, the examiner, after taking viva of 1 or 2 candidates, generally it happens that he'll tell you, Dr. Saab, what are the positive findings and how will you manage the case? How will you manage the case? So from here, your viva will start, that how will you manage the case? Okay, so for managing the case, this should be the approach. Sir, I would like to approach the patient further. Please don't make it a habit and say, ki, sir, I will do a tympanoplasty, or I will do a surgery, I will do a MRM for the patient. This should not be the first answer. Your first answer should be, sir, I would like to I would like to investigate the cases further. Now he'll ask you, what further thing would you like to investigate? So the first and the foremost thing is a PTA. This is an individual viva question also, and this is how you can prepare yourself also. Okay, that sir, PTA will be done to know the degree of hearing loss, to know the type of hearing loss, for documentation basically, and for the medical legal purposes. Okay, so this is the reason why we do PTA generally. Okay, after PTA, what to do? Sir, automicroscopy. Why to do automicroscopy? Sir, to confirm diagnosis. For suction clearance, site of granulation tissue hai, so we can take a biopsy from that place. What are the status of ossicles? We can confirm it. We can confirm the site, margin of the perforation, and in case if you want to examine the attic, retraction pocket, all those things we can examine. Isme se at least 2-3 points you should speak in a, like whatever he says, automicroscopy, thug, 1, 2, 3 points. Okay, if you can remember more, fair enough. Okay, moving ahead. So now here comes the one of the dilemma question. Dilemma question मतलब होता है कि examiner might say कि why have you done so, and if you will not do, why have you not done so? Getting my point? Because everybody gets fraudulent. If you say X-ray mastoid, he might say कि in today's technology, why are you doing mastoid? Why don't you directly do a HRCT TB? And if you directly say HRCT temporal bone, then again he might screw you. That the people are so poor, why are you exposing to radiation, blah blah blah, all sort of things. So the ideal setup should be start with the basics first. sir, I would like to do X-ray mastoid of the patient. Now again, very same traditional questions. What do you see in X-ray mastoid? We'll start with, sir, I'll come to know the pneumatization of the mastoid. ऊपर से आपका ड्यूरा आपका tegment का plane I'll find. पीछे से आपका sigmoid sinus का plane I will find. These are 2-3 things which you will speak in your X-ray mastoid. Now, second comes of HRCT temporal bone. In HRCT temporal bone also, like in today's work, everybody does a HRCT temporal bone for every patient. In repeated cases, in all those cases. But there are few senior surgeons, those who are like I'm the boss of otology, I will see it on the table itself and I will manage it. Okay? There are few of this old school thought also. So they generally don't do it in case like they are very confident in the pre-op that what are the findings, how they are going to manage it. Okay, so what details can be there? What why will you do HRCT temp? One is you can know about dura, you'll know about sigmoid sinus. Okay, how is the hypotempanum? Okay, any evidence of your jugular bulb, high riding bulb? Okay, then comes the important thing, root of facial nerve. Okay, then you can study about the ossicles. Somebody else? No. Okay, and if there's one tip for you, if you don't get anything else after this, sir, say, sir, this is our institutional protocol. Like if it's in your institution that they don't do HRCT TB, you can very well say, sir, in our setup we don't do it. So it is accepted, but you are supposed to know why you will do HRCT temporal bone and what are you supposed to look over here. Now, in HRCT temporal bone, keep in mind that like NCCT PNS, most very important for you. Many scans, many sections are there. Same here. Reading a HRCT temporal bone is again of utmost importance. Okay? But there are multiple sections. They'll push you that read it. What all complications can be there? What are the options available to you? So you cannot miss it. Okay? So abhi for this week and the next one we'll be focusing on NCCT PNS itself. After this PNS thing gets completed, we'll start our paradigm shift on HRCT temporal bone. Okay. Now coming to the second thing. He'll say like the surgery we do, what are the aims of doing surgery? So aim of doing surgery is basically three. First always remains the eradication of disease. Second aim remains your restoring the hearing. And third will becoming a you can restore the normal anatomical appearance as close as the initial one. But the first one remains total eradication of disease followed by restoring of the hearing. Okay. Now comes one of the very, very, very important thing. That Dr. Saab, how what type of surgery will you perform? So over this question, I'll tell you that every institution has different sort of practices which they follow. Like how we were taught, at our age and experience, canal wall down, if it's the case of cholesteatoma, canal wall down is the surgery which we will perform for the patient. Keeping in mind our experience, sir, I'm fresh from PG. I'm in my final year. I'm completed my PG. I'm awaiting my results. So I'll taking on the patient with canal wall down. Now over here also, it is a plus minus question. Why? Examiner might tell you that Dr. Saab, if you cannot do an entire canal wall down hysterectomy, please don't touch the patient. Some experienced person can also do that. Or if you say that Dr. Saab, I'll do this one canal wall up mastoidectomy, but he'll ask you that are you confident enough that you'll remove all the cholesteatoma? So here is a dilemma. Okay, how to answer. So this is how sorry, we were told that at your age and experience, you can answer this thing that sir, I would like to do a canal wall down so that I will have adequate space and my visualization so that I can have the complete removal of cholesteatoma. So first thing, जो हमारा aim है, total eradication of disease will get completed. So here only I would like to mention one question. Please read about it. One is canal wall down, canal wall up. इसका advantage और disadvantage. Given in Scott Brown, तो यहाँ पे आपने कुछ याद करना है 2 over here, 2 over here and 2 over here. तो ठीक है, this should not be forgotten. This is very important. This things are shared in the 20 pages का जो document है, PDF है. Go through it. It contains all the basic questions of your CSOM Commerce Viva. ठीक है. apart from this, second question you should remember, sinus tympani, इसमें boundaries are important, इसका CT is important and types are important. A, B, C पहचानना आना चाहिए. Third, facial recess, and fourth, without doubt, it is Prozac space. Your management of cholesteatoma will start from Prozac space. If you flunk in it, if you don't know what are the boundaries of Prozac space, उसका आगे बढ़ेगा नहीं कुछ भी. ठीक है? Don't expect him to ask you anything else. Okay? So basics thing you should not falter. ठीक है? चलो, moving ahead. Very important question. Okay, Dr. Sir, why do you say it is squamous disease? Okay, so you can divide it, sir. Your history findings. Based on history, why is it? Based on examination finding. So in history, what are the histories? The first thing is the discharge is foul smelling. Now, can somebody unmute and tell me why the discharge is foul smelling? Take a try, somebody.
Osteoarthritic organism.
Yes.
Osteoarthritis.
Osteoarthritis. ठीक है. Exactly. So the keyword which you should focus on, that it is osteitis, and there is constant degradation, there is constant decaying of the cells over there, basically, which are the ossicles. So it produces a foul smell and the blood stain discharge, because there is a granulation tissue present over there. Cholesteatoma is basically a granulation tissue. The discharge is blood stain, scanty and continuous. Okay, sir, as it is a relentless process, it is a continuous putrefaction and the osteitis which is continuously going on, it is a continuous discharge as compared to the mucosal where the discharge is profuse. The patient says that, sir, the discharge comes out and it even spills on the pillow also. It is so profuse. Why it's so profuse? Because middle ear mucosa, it contains which type of cell? Goblet cells. ठीक है? So goblet cells, जैसे they keep on vomiting the mucus. ठीक है? So it starts, like, keeps on coming out. So this is like how you will say, sir, based on my history per se, like till now where I have reached, this is as per me it is squamous, because these are the findings. And it might happen, see, it's a friendly advice to you, it might happen that you might feel कि यार ये तो mucosal लग रहा है, but you will be, मतलब, please make double sure that in history these are the points you have to cover. You should not dig your own grave that in a squamous case you say, sir, the discharge is profuse. The whole viva will roam about that same thing. Okay, so you know from beforehand that my viva is gonna be on squamous, so better focus on these things. Okay, it might happen that a patient might say कि sir मेरे को बहुत ज़्यादा discharge आता है, but please stick on the basics that before passing the exam. Okay, now coming to the next set of questions. Now, can I have the name of retraction for pars densa, please?
Right, sir.
Sade classification.
Sade classification.
Yeah, Sade classification. We pronounce it as Sade. In a more, I didn't get it. Yeah.
For pars flacidus toss classification.
Yeah, exactly. And we all remember it, like a small mnemonic, like when we take a coin and we we toss it like this, na? So it goes up. So up ऊपर क्या होता है? Flacida होती है. So this is the toss retraction. This is the Sade retraction. Okay. And what are the grades? Please rectify it. ठीक है? It shouldn't be like even in the again the same thing, ना? कि ये नहीं होना चाहिए कि in confusion you are saying कि sir there is dimpling, इसमें हो रहा है कि इसमें हो रहा है, you are confused. So that shouldn't happen. ठीक है? There are some things you cannot make a mistake. So please rectify it. Very important. Okay. Over here there will be certain other questions which I'll keep on sharing with you. Okay. So this remember this, the answer is given in that PDF which I have shared. Otherwise, see it from the Scott Brown. With the images, they have made the exact table. Just go through them. Second question.
Okay.
टिम्पनोप्लास्टी क्लासिफिकेशन, ठीक है. It seems easy, ठीक है, but your examiner might be an old timer. He might start from this only. The defined tympanoplasty. What are the types of tympanoplasty you know about? So 1 से लेके 5 तक 1 2 3 4 5 थक. What is like that Wolstein classification? What is TOS? You should start with the basics itself. Okay. I'll share the PDF of Wolstein and TOS after the completion of class. Okay. Second question is Mary. Mary is an individual OSCE in itself. One. And how to go about Viva point. Let me just give a chance to you. When you examine your middle year, ठीक है, at the examination of middle year में, you speak from yourself, sir, the Mary score is this and this, and look at the examiner. Now, when you will speak that word, utter that word, out of the 10 Viva that he has already taken, you are the only person who has taken the name of Mary. Okay, I'll ask you, what is Mary? So you are ready with what is Mary? Full form से लेके, what are the scores, what are the types, why is it important? You know everything. So you blurt it out rampantly without stopping. So that gives a good impression on the examiner. And if you do 1 or 2 times in the entire Viva, you are straight away pass in that section. 50% तो आप cross हो गया. Depending upon how you take the Viva to further discussion, you will get 60% marks, might be 70% marks. Got my point? So these are the things where you have to capitalize. ये एग्जाम के एक दिन पहले you cannot rectify it. You say कि बाकी दिन तो I'll just manage, और एग्जाम से पहले एक दिन पहले मैं याद कर लेता हूँ. You will forget it over there. And if you forget it, so then basically you are digging your own grave. तो ऐसा मत करना. Apart from that, second question, which is your OSCE question, oops and sorry, just below the paragraph of Mary, they have given this answer. And second will be your Belfast rule of thumb Glasgow scale. ठीक है, आंसर ऑफ ऑल आर शेयर्ड इन योर जो पीडीएफ अभी 20 पेजेस का है. कीप रीडिंग इट. ओके, यू विल नॉट बी एबल टू लर्न ऑल द क्वेश्चंस इन वन डे. आई थिंक 100 क्वेश्चंस आर देयर टोटल. ठीक है, बट यू हैव मोर देन ऑलमोस्ट अभी 100 डेज के आसपास है एग्जाम के लिए. 2 मंथ से 3 मंथ्स का टाइम होगा पेपर के लिए. ठीक है, टिल दैट टाइम यू रिवाइज इट, आई से 5 टाइम्स 10 टाइम्स. ठीक है, तो thing will become imprinted into your mind. Okay, now coming to the types of cholesteatoma. See how what I have seen in the cholesteatoma questions, like 3 years they were conducted in our institute. Then I gave my exam 4th year. After that 3 years, I'm down. The 3 sessions are taken down the line. I'm seeing what kind of questions they are happening to us. Old timers of examiner, they ask you definition of cholesteatoma. One. Then they ask you types of cholesteatoma. And if you are unlucky, if your patient is like that 8, 9, 10 years old wala boy hai, your whole Viva goes on this pediatric cholesteatoma and congenital cholesteatoma. Okay, so don't be shocked that you have learned only about jo apna hum routine adult पढ़ रहे, and your patient is a 10-year-old boy. Like it happened with me. My Viva was on a 10-year-old boy. ठीक है, so I was sure कि case I knew that this is CSOM squamous only. One day before I was able to manage the case. Okay, so the entire thing will go over here. Okay, that what is the definition, what are the types. Okay, so I'll share with you people the definition, and जो classification है उसमें तुम्हारा ये वाला important है, Derlaki and Clemens criteria. ठीक है, so just this is the like definition part, please remember it. ठीक है, definition is from your Scott Brown itself, and this is the Derlaki and Clemens criteria. Okay, modification इसका Levinson criteria है, that is again mentioned. Please have a look. I'll share it with you, this same PDF in a way. Okay, now after this, coming to the various theories of it. This is how during my residency I learned it from the notes and sources I was following that time. This is your deeds. आई से कुछ नहीं, माइकल, डीड्स माइकल. फार्ट से आपका हो गया फ्रीडबर्ग, एमी, रूडी, टॉस, साडे. See, this is my experience. Theory, like details I have mentioned below. You can see over here. I'll just like to share one thing. When you go about it, what are the theories? Most of them will sound similar. ठीक है, just to add on confusion, एक दो word इधर उधर होता है and the name, entire name changes. But as a exam going resident, okay, you need at least to mention the names confidently. ठीक है, you should be able to mention the names confidently.
Sir, it's not clear. Sir, your voice is not clear, sir.
Voice is not clear. Okay. Anybody else also facing the same issue? So, Dr. Aminana, I'll request एक बार आप log out करके will you please log in again?
Yes, sir.
I'll wait for you. Please log in again. मुझे अगर कोई चीज नीड हो तो उनको मैसेज डाल के छोड़ दो. Yeah. Is it okay now? Hello, is it okay now? Hello, is it okay now? Sure. Thank you, Dr. Sir. Sorry for the interruption. Okay, so just a minute. One of you is waiting to join. Okay, so as I told you that most of the things will seem similar to you people, but when you answer as an exam going student, be confident in telling the names. ठीक है, names में you shouldn't falter. And how I used to follow that, I was not able to remember them confidently. So I had learned one or two names of theories like TEEDS है. So TEEDS को I had learned word by word. So that if somebody asks me, so I'll tell the name and I'll start with TEEDS only because मेरे को यही आता है. Okay, so let's go ahead. So this these are the details of theory. In case you have not made your own notes, you can go through this or from wherever you are studying, but you should know the answer per se. Okay, moving ahead. These are the stagings over here: Derlaki, Clemens, Pottsik, and Nelson. These are the three names. Okay, so please remember them. These names I have mentioned, they can even ask you the same in the OSCEs itself. Now, coming to the three named management classifications. There will be one Stamco, there will be Cole, there will be no Jaws, and after that, there will be this Samioto. Okay, so for these things, I'll just tell you for Samioto, there is a this is basically is somebody using it in their hospital. It's a post-operative operative classification that what all things you have been doing. Is there anybody जिनके hospital में use कर रहे हैं Samioto? Okay. So I'll हाँ बोलो. No, we don't use it. अच्छा, you don't use it, ना? ठीक है. So it's more or less, I think it's a I'll say academically only it's there. So I'll share you the link for this Samioto. This is basically it is a sort of app of Samioto is also there, but as a resident, our faculty insisted us to fill the Samioto classification. Okay, so this is for the tympano part and this is for the mastoid part. Okay, so they'll keep on asking you that what is the site you are entering. Now coming to the Stamco thing. For Stamco, you should remember the difference. Okay, this is the S1, that is your difficult anterior area. This is your S2, and T is basically the tympanic cavity. That's the easy part. A will be your attic, and M will be mastoid antrum. So that takes care of your stam. C is for the complications that can occur. O is whether the ossicles, what are the ossicles status which is there for the patient. Okay. So please remember this, okay? The full form you should remember. This can come as an individual OSCE also, and this can come as a वाइवा क्वेश्चन तो है ही है. ठीक है, चलो इसके बाद आपका अगला क्वेश्चन जो बनेगा, जस्ट अ मिनट. Now, what is the full form of this ionojaws? I hope you people know the full form. European Academy of Otology or Neurotology, and JOS is Japanese Otological Society. Moving ahead, now comes the big daddy, main cholesteatoma. Okay, so you should know the definition, theory over here. Okay, and any definition you can remember. Okay, these are the three main things. One is given in Scott Brown, one is from Shambog, and Shambog se aaya hai this book Shambog. Okay, there is one chapter called as Complication of CSOM. Please go through this chapter from Shambog in depth, A to Z. ठीक है, generally I keep on telling कि थोड़ा शुत्री से पढ़ लो, keep on skipping it all, but this chapter is very important and it's very nicely given in your Shambog. Okay, चलो moving ahead. Now, what are the theories for this cholesteatoma? You can remember it कि किसी TB patient में आपने CI कर दिया, CI मतलब cochlear implant कर दिया, तो TB is tumarkin, B is your basal cell hyperplasia, May is for your metaplasia, and this will be your Cawthorne theory. I is for your invagination theory. These are the details. Any one you can remember. Invagination, Cawthorne, जो तुमको याद करना एक याद कर लो. This you should remember because this is the latest part. 2015, Jackler's theory of mucosal traction. So you should remember the name, Jackler. You should remember the year and you should remember the name, mucosal traction theory. I'll say the words are almost same. It's just to increase the headache for the patient of the patient resident. ठीक है? Now this is a very important question. That why is your cholesteatoma? What are the things that causes the damage? So please remember this thing. Okay. This is your metalloproteinases 2 and 9, TNF alpha, interleukins, एक rank ligand important है, and caspase activation. It is from Scott Brown 8th edition. ये जो enzymes के नाम है, please remember it. Now second question, DD of chronic discharging ear. The first becomes your cholesteatoma. Second becomes your TB. Third become your granulation tissue. Please bear with me for next 5 minutes. We'll start with the जो slides वाला है. This is the operated cavity per se. Tumor and XYZ. These are the DD of cavities in mastoid. And for chronic discharging ear, basically, one which we are dealing, that is the CSOM. TB is everywhere. Third is again very important, malignant otitis externa. Okay. Now comes with the very important question. Now can somebody tell me Rennes and Weber में which is the more sensitive test?
Weber.
Okay. So that's the correct answer. Weber जो होता है it lateralizes 5 to 7 decibel. जबकि 256 को positive होने के लिए you require 15 dB of loss at least. So Weber is more important. Okay. This we know. ठीक है. There's no fun in telling that we use 512 because it has a balance of your tone decay and vibration per se. And after this, you should remember one more thing. After Weber's, there's one test called as Stenger's test. This can be placed as a OSCE based question for you. This is for your, why is it used? For detection of malingering. Yeah. Apart from Stenger's, there is one more test called as Shimani-Moose, which is not important. Name, if you want to remember, you remember. Otherwise, remember the name, Stenger's test. What is Stenger's phenomena? Where is it used? Okay. Now, after this examination, में इसके अलावा what else you can say? That is your neurological examination you have to tell. तो अपने केस में facial nerve का examination is a must. Your case will not finish until you say, sir, otoneurological examination within normal limit. ठीक है? And एक और जो last point हम बोलते हैं, that is fistula test. Now, I would like to again take last 1 minute for this section and talk a few words about fistula test. There is a very high possibility that the examiner, while giving the viva, he'll ask you, Doctor, what is a fistula test? So there is one way of telling fistula test is that, sir, fistula test mein I press on the tragus of the patient develops giddiness. Sir, this is fistula positive. And there is one way of telling, sir, principle. Sir, these are the following methods of doing the test. I can either press on the tragus, I can use the Siegel speculum, and these are the interpretation. So this is positive, this is negative, this is false positive, this is false negative. Getting my point? So it will create a better impression for you, and as I say, 2-3 of these questions will straight away take to you more than 50% marks in the long case viva. Long case अच्छा हो गया, your passing probability is gonna increase indefinitely. Okay, and after this you have to comment on nose and long case and throat तो बोलना ही है, nose भी अपने लिए important है. Okay, he'll ask you what can you get in nose, so you can tell कि sir in cases of bilateral COM there is likely to there is a central pathology, so therefore I have also examined the nose of the patient. Now coming to the final diagnosis, उसके बाद से we are gonna start with presentation. ठीक है. So basically you have to use full form. First thing from my side, बाकी सब आपको पता है, फुल फॉर्म नहीं छोड़ना है, वहां पे COM नहीं बोलना, क्रोनिक ओटाइटिस मीडिया, लेफ्ट स्क्वामस, राइट स्क्वामस, व्हाटएवर यू वांट टू से, विद जो भी हियरिंग लॉस आपका आया हो, मॉडरेट, माइल्ड, मॉडरेट, सिवियर, व्हाटएवर, कंडक्टिव हियरिंग लॉस अनलेस अनटिल आपको कुछ और मिल रहा हो, विद और विदाउट कॉम्प्लिकेशन. गेटिंग माय पॉइंट? मूविंग अहेड. So over here, what I have done is, there is a case presentation basically. I'll take 15 minutes minimum, maximum 20 minutes. इसको ऊपर नहीं लूंगा, ठीक है. I'll just take you through how to give, what are the history में क्या क्या points अपने को बोलने हैं, what questions will come and what are we supposed to read and how we are supposed to answer them. Okay. So my patient so and so, इतना year old, resident of Delhi, presented with complaints of discharge from this year since 1 year duration, and second complaint was decreased hearing both years 1 year duration. Okay. Now pehla question, what are the cardinal features? Acha, I'll just tell you, this case I had presented from my hospital in the NB web portal. So I was the one who got rogered nice and proper for this case, from my department also, from NB also. But the thing was that after giving this case presentation, it like confidence आपको आता है. I gave 3-4 presentations more, and this CSOM commerce was not a like, I was like हाँ ये तो pass कर जाऊंगा type से. Okay. So cardinal features of ear disease, first question. ठीक है, and you have to describe the discharge. Examiner will ask you, Doctor Saab, describe the discharge that you are speaking. So you have to tell, sir, discharge is scanty, it is continuous, it is foul smelling, it is blood stained. And same, उसका तुरंत क्वेश्चन पूछेगा, why, and you are ready with your bat, you have to hit a sixer. वहां पे कंफ्यूज नहीं होना, करके गलत नहीं बोलना, इसका आंसर you have to give it correctly. Okay. So, sir, the discharge is continuous, thick, purulent, scanty, blood-stained, foul-smelling discharge, whatever you want to answer. कोई भी negative अपने लिए गड्ढा नहीं खोदना. You don't dig your own grave. यहाँ पे कुछ भी don't put anything which is of mucosal. नहीं डालना. You don't put anything. Giving viva is an art. You have to develop it over the next 2-3 months. Some people will be having it. Please polish it nice and proper. And like if you are like me, the average backbencher, so please develop it. This is the time where you have to work hard on it. Okay. Now, what are the history of present illnesses? Sir, he also complains of decreased hearing both ears. Whatever it's there, you have to tell, sir, left more than right, onset, progressive, continuous. Okay. This I have mentioned so that to tell that he is using his mobile with right ear. Matlab, left ear mein his hearing is more. Now, the question which comes over here is, what is fluctuant hearing? What are the causes of fluctuant hearing? Can somebody unmute and take a try?
So, Meniere's disease.
Very good. 1, 2, 3. Dr. Saab, I'll ask you, how many cases of Meniere's disease you have seen? Answer सही है. Don't think that your answer is wrong. Answer is correct. But अभी बताओ Meniere's disease कितना देगा? Sorry, I didn't get you. कितना?
नहीं, सब कुछ नहीं देता.
नहीं देखा ना. in my अभी मेरे को हो गया residency plus almost 2.5 है ना. I've seen only one case of Meniere's, that to my faculty had diagnosed. वो वापस से वो कुछ सिनाराजिन लेने आई थी, तो I just saw कि ये ECOG है, ये सब कुछ है ना. So our third answer will be Meniere's disease. ठीक है, answer is correct. First thing is your fistula. ठीक है, we keep on talking कि fistula. This is the first answer. Second is active disease. Active disease मतलब होता है when your ear is already full of discharge. ठीक है, और in a case of, if this case develops mucosal disease also. ठीक है, if this case aggravates, so in that case also you'll have fluctuant hearing. And third option, obviously it's Meniere's disease. ठीक है, answer is correct. Moving ahead. Sir, there is no history of associated otalgia, tinnitus, vertigo, oral fullness. So this I will say that I'll just discuss it. And sir, there is no history of associated fever. There is no history of swelling behind the ear. There is no history of any facial asymmetry. Okay. So we will ask you, Doctor. Sorry. Why did you ask fever? Sir, there are complications of CM in which fever is associated. Acha, tell me where this fever will be there. Sir, fever can be there in lateral sinus thrombophlebitis. Now, can somebody tell me which type of fever is there in lateral sinus thrombophlebitis?
Picket fence fever.
Great, very good. ठीक है, this is picket fence fever. इसके अलावा 3 questions which will come. There is a empty delta. ठीक है, there is a empty delta sign over here. 1. What is the pathology? This is a OSCE, okay? What is the pathology behind? ठीक है, and दूसरा, why there is pallor? ठीक है, so for reading getting the answers, उसमें already shared है on those pages, but you should go through Shambog. Second time I'm repeating in the same class. ठीक है, it is very important. I realized it after my residency. ठीक है, so that's why please go through it multiple number of times. Every time you read it, you'll find something new. Okay, first thing. Second thing is brain abscess. Okay. Over here, the question which you will be asked is, what are the stages of brain abscess? Okay, I'll be sharing with you. 2. And third comes the swelling behind the ear. So he will ask you, what kind of swelling can be behind the ears? तो जो अपने रूटीन हम लोग पढ़ते हैं, these are your bizold abscess, mastoid abscess, Lux abscess, Sertoli abscess. All these are OSCEs basically, individual OSCE है. So we'll be seeing through them as we progress through it, through the journey of entire 2 months. Okay? So these are the questions. Questions should come into your mind कि यहाँ से ये question आएगा. Answer will keep on filling. Okay? Now, sir, there is no history of trauma. Acha, one more thing. While presenting the long case, all the headings should be filled. It shouldn't happen that आपने HOPI बोला and HOPI के बाद आप directly आप पहुंच गए, sir, my patient is a vegetarian and his sleep and cycle is normal. No, everything should be filled बीच में. देखो, no history of trauma, head injury, exposure to loud noise, consumption of ototoxic drug. Everything में whatever you speak, he will ask you why did you ask it, and be ready for this answer. If you don't know why, don't speak. Simple thing. If you don't know the answer why, don't speak about it. गायब कर दे उसको. आगे चलो. There is no history of known chronic illnesses. He'll ask you which chronic illness. You'll tell diabetes. He'll ask you why. You'll tell, sir, in diabetes the healing will get impaired. I'll have to get a PAC done, so I have to know about it. You should ask about TB. You should ask about viral diseases, so that you should be careful about them. Coming personal history, not very important. Now, why is this important? Smoking. This comes in the Mary's index. Okay. Now, coming to family history, please stay with me. Last 10 minutes. No history of similar complaints in the family. No history of any allergy in the family. We can ask you that this type of, because some allergies are there, like allergic rhinitis. This can lead to adenoid hypertrophy, and this can lead to multiple diseases. Okay. Treatment history. Mention it. Even if there is no treatment history, let's write, sir, there is no history of any treatment taken from outside. He's coming to us for the first time. Good. Now, here is from where examiner starts testing you. अगर आप यहाँ तक पहुँच गए, it means you have done the good work. And there are quite a number of chance that आप अगर examiner के पास जा रहे हो, he will be tired after listening the same things from 2-3 person. 4th, 5th तक आते he's like, summarize the case. What are the positive findings? Tell me how you will manage the case. So you should be ready with the summary for the patient. So this is the I've taken out the important points and filled it over here. This is the summary till the history. Now coming to general physical examination. There is one very common doubt कि सर मैं तो ENT का examination कर रहा है, मेरे को बाकी करना है. Yes sir. Long case में it's a big yes. ठीक है, but you should be careful that अगर आप BP बोल रहे हैं, I'm saying BP is 126 so and so. So BP apparatus कहाँ रखा है ये मुझे पता होना चाहिए. Because if examiner asks me कि how did you take BP, So I shouldn't cut out a sorry figure कि सर मैं तो ऐसे ही लिख दिया, मैं तो गोला मारा नहीं. You should know कि सर वो टेबल के पीछे रखा है, तूने लिया नहीं लिया that is immaterial, but you should know it. Don't bluff out, entirely bluff नहीं करना. एक, touch the patient. ठीक है, it shouldn't happen कि examiner is just looking at you that you बस ऐसे दूर बैठ के देख रहा है and you have written the pulse whatever you want to write. Write it properly because he will ask you why is pulse important. It will take your viva towards tachycardia, fever, all those things. If you have not, you don't have this thing, just tell him, sir, I wanted to measure the BP, but BP apparatus I could not find. Systemic examination, say, sir, CVS, CNS, PA, respiratory, normal. But speak about it. Systemic में people have the ego of listening about everything. Then come to your ear examination. Okay, now ear examination में these are the things you can divide it. Sir, preauricular, pinna, post-auricular, mastoid, EAC. और अगर आपके institute में if you have one or two more things you can add over here. Okay, in everywhere be ready. Yeah, in your mind you should be ready. What abnormalities can be there? ठीक है, sir. In the preauricular region, no abnormal, and you should tell the examiner, sir, I am telling about the right ear first and the left ear at the later stage. Okay, so you can tell about it कि sir preauricular में ये हो गया. Now he can ask you, बेटा preauricular में आपने क्या देखा है? If examiner asks you, you just tell him कि sir in my patient there was nothing, but we can see preauricular sinus, preauricular fistula, all those things are preauricular tags can be there. So this we can be able to appreciate. अच्छा, what you will appreciate in pinna, तो you will tell sir microtia हो सकता है, anosia हो सकता है, ठीक, cauliflower ear हो सकता है. Same. Post oral और mastoid में what you can see, so you can tell about your abscesses. Now why is EAC important? I just want to mention about one point only. बाकी तो आप सब आपको पता है. This is something called as deep canal wall erosion. Are you with me? Have you heard this word before? Canal wall erosion. अरे सुना है कभी? Have you heard about this any time before? Like, am I audible to you?
Yes sir, सुना हुआ है.
अच्छा सुना हुआ ना, हाँ बस वही सुनना था. ठीक है, this is a indication for canal wall down. Okay, so that's why I wanted to put this word again कि sir already canal wall is eroded, so I would like to take it down. Second thing which you can do see over here is lux abscess can be appreciated. ठीक है, there is sagging of the posterior superior meatal wall. Okay, so these things you can see, and whatever positive findings you see, you just tell it over here. Now coming to the endoscopy, ठीक है, left side or right side, whatever you want to say. Now there's one more bit of advice from my side. Like what happens, we just jump upon the perforation. Sir, tympanic membrane, sir, there is a moderate size of perforation in this thing, there is retraction. First, try describing the normal features. Sir, I could appreciate the anterior malleolar fold, I could appreciate the posterior malleolar fold, or whether you are able to appreciate the external landmarks or not. One thing तो ये हो गई. दूसरा चीज आपका हो गया, sir, the start from anything first. You can either start from pars tensa, you can either start from pars flaccida. So if you start from supposedly pars tensa, so you say कि sir pars tensa is retracted and see. Sir, pars tensa is retracted, Sade grade 2. Yeah, supposedly, like if I am answering, I'll say, sir, grade 2 retraction. Now he will ask me, grade 2 retraction, you said grade 2 retraction, tell me what is grade 2 retraction. So speak about, sir, this is Sade retraction, Sade and Burko's grading, 1, 2, 3, 4. Even if he has not asked, believe me, 20 minutes you are getting for that viva. है ना? So you have to keep the examiner engaged. ठीक है? तो रिपीट एवरीथिंग 1 2 3 4 ये होता है. सर पार्स फ्लैसिडा में अपने आप से बोलना शुरू कर दो. सर टॉस ग्रेडिंग है 1 2 3 4 ये है. गेटिंग माय पॉइंट? So you have to tell the examiner that you know it is impossible to judge you in that 3 hours of that practical or paper whatever it is there. ठीक है, whatever you have read in your entire 3 years, it is impossible to judge. So you have to tell the examiner कि भैया मेरे को आता है, मेरे को पास कर दे, ठीक है? I know it, please pass me. So please keep on speaking, make the habit of speaking. It shouldn't happen कि वो तुमको डांट दिया and you go into your shell. Now you are not able to answer anything. So he will fail you. People are very toxic outside. They love failing people. Okay, so keep that habit of practice of speaking the answer. Okay, sir, in the past Flacida, I can see retraction grade 1, grade 2, whatever you want to say, whatever is there. Sir, there's a PSRP present. Sir, I can see the sac. I can see the anterior end of it. Okay, same goes to the other side. Okay, after the examination of ear, you go to the tuning fork test. ठीक है, we have already discussed the questions कि tuning fork से क्या-क्या questions आते हैं. After that, otoneurological examination, you have to mention, this is the entire thing. Okay, this is as per the NB. I have presented it in NB, so it is tested one. Okay, fistula test negative. All your viva will go towards fistula test. Cranial nerve examination, पहले एक बार check कर लेना. It should be normal. It shouldn't happen that you write it and he is having some palsy, तो फिर तो मुश्किल में आएगा. So just एक बार देख लेना. Normally it doesn't happen. CSOM, squamous, you will not get any complicated case, but still you should have a look at least. Okay. Gates, spontaneous nystagmus, rhombus, cerebellar signs. Okay. Now over this also, sir, there is no external deformity. Columella appears normal. Nasal vestibule, nasal septum में anything is there. Over here you will be able to see. बस यहाँ तक है. बस ठीक है. Since this was a viva practice, so I had included the endoscopy image and the diagnosis and HRCT temporal bone image also. So this is not required for you per se. You will not be able to. You will not be asked about HRCT temporal bone. Okay. So from my side, please practice. What are the questions of the history? Keep asking yourself whenever you are practicing for CSOM commerce. Ask yourself. Okay. Points of examination, and most important, how will you answer this question? How will you manage the case? Okay. Again, I would like to blatantly end it. This is the most important part. From wherever you have studied, please read about it. You should not fudge up it over here. After the class, I'll share the PDF also and share link of some other discussions of PDFs of some teacher of reputed teachers. Okay, this is like in a very friendly format. I've told you, भैया ये question है, ये इसका answer है, पढ़ लो, important है. ठीक है, इसमें when that exam वाला stress factor adds ना, so it becomes little bit hectic. Okay, so I'll share you few videos. Videos of are about 1 hour duration. You can watch it in 1.25 or 1.5 के speed से and revise it once or twice. So you'll see that 80-90% of the questions are the same which we have discussed normally. केवल 10% होगा जिसमें you will be getting caught that अच्छा this is something new. So whatever new you get, please share with everyone others also, and it will be beneficial for you also. Okay. So till now, any point from your side, any doubt from your side, any other issues?
Sir, how about the throat examination?
See, for the throat examination, I'll tell you, you are the DLO ना, आपका पेपर अभी होने वाला है?
हाँ, yes.
हाँ जी, ठीक है. So take your entire thing. Your headlight should be there with you. For nose examination में anterior speculum should be there. Headlight होगा, एक tongue depressor भी carry with you. Okay. So throat examination generally it doesn't have any positive findings which will contribute to your ear case per se. But since you are telling the details about the nose case, ठीक है, so it's better to mention, sir, in the throat there is no abnormal activity. Sorry, no abnormality found in the throat. There is no positive thing which will affect your ear case per se. Okay.
Okay, sir.
Okay. Great. Chalo, और कुछ anything else? चलो, all the best. Bye. Good night.
Sir.
हाँ, बताओ.
Sir, can oral polyp, the oral polyp can come as a question, because in our center there was a scenario that oral polyp was a case and they restricted the whole viva around that only.
See, Dr. Sir, one thing I'll tell you, in DNB anything can come. ठीक है, एनीथिंग मतलब एनीथिंग कैन कम, ठीक है. इट जनरली डिपेंड्स अपॉन द टाइप्स ऑफ केसेस व्हिच आर देयर, ठीक है. आई हैव सीन द एंटायर सिनेरियो. सी आई वाज अ डीएनबी कैंडिडेट, मैंने एमएस नहीं किया है, आई एम अ डीएनबी कैंडिडेट एंड आई हैड माय बैचमेट्स हु वर डूइंग द एमएस. मेरे बैचमेट है बट दे वर डूइंग एमएस फ्रॉम द अदर कॉलेजेस, ओके. सो इन एमएस दे आर वेरी कंसिडरेट अबाउट द रेसिडेंट्स दैट ये फेल नहीं होना चाहिए unless and until you have abused your HOD, ठीक है. बट इन द डीएनबी दे हैव, आई डोंट नो व्हाई पीपल हैव कि इसको कैसे भी करके लुढ़का दे टाइप से, ठीक है. इट हैपेंस, आई हैव सीन इट, ठीक है. सो दे माइट पुट अप दिस सॉर्ट ऑफ केस आल्सो दैट यू वुड हैव नॉट हर्ड आल्सो, ये ऐसा क्या है करके. In those type of cases, how you should proceed is generally what they look is that how will you proceed with the case. It shouldn't happen that oral polyp आया तो like आपके पास OPD में आया oral polyp, so how will you proceed with the case कि sir I would like to probe the polyp, I would like to do biopsy of the polyp, I will go with a CT scan for the patient, HRCT temporal bone करेंगे. So these are the things which you can like mention about it, but rest assured हाँ
उसमें तो ऐसा बोला था, लेकिन मतलब एवरीथिंग वाज गोइंग अकॉर्डिंग टू द अप्रोच ओनली. बट जब वहां पर उसका मैनेजमेंट पूछा तो आई एक्चुअली सेड इट एट दैट टाइम कि इट वाज अ केस ऑफ मैस्टोइड एक्सप्लोरेशन, बट ही डिडंट वांट दैट आंसर एट दैट टाइम. बिकॉज़ तो ही आंसर लाइक सिंपल आईवी एंटीबायोटिक्स एंड ओरल पोलिपेक्टमी विल डू द जॉब. आपको ये बोलना चाहिए था. मैंने बोला सर
सी दैट इज आई विल से बैड लक, है ना. यू डोंट नो हाउ दैट पर्सन इज how his day is going, how at what time his flight is there. It will happen. तो तुम्हारा वाइवा चल रहा होगा, 2 घंटे बाद उसका फ्लाइट होगा, तो he'll be like फटाफट निपटाना है, ठीक है. If he will fail, he'll fail you. If he'll fail, he'll pass you. So don't take it to your heart, ठीक है. Just practice your hard work and like believe in God. Everything will go all right. Okay. It is a very rare thing that to go like leave entire CSOM squamous and fall towards oral polyp, which is I am like very I'll say lesser known complication of these things. Okay.
Okay sir.
चलो take care भाई.
Okay sir. Thank you sir. Good night.
Okay. Bye. Good night भाई.